The next speaker is Dr. Martin Hingle from the early phase product development here in Basel, Novartis, to talk about challenges in oral nanoformulation prediction by physiologically based biopharmaceutics modeling, or PBBM.
Okay, I'd like to start saying thank you to the organisers for inviting me to present at this summit. So what I'll be talking about is the challenges in predicting oral nanoparticle performance by physiological-based biopharmaceutics modelling. So what I'll be covering is the fundamental drivers of bioperformance, why do we need nanoparticles, then talk about the PBM modelling, mainly talk about the absorption, distribution, metabolism, and excretion, what the predictions look like, and go through a case example, then going on to the challenges affecting the absorption behaviour of these oral formulated nanoparticles, and then lastly going into biorelevant and biopredictive methodologies. So the fundamental drivers of the drug bioperformance are the solubility and permeability, and we do the early stage characterisation via the biopharmaceutics classification system. And this divides things up into low and high solubilities and low and high permeability. The BCS class 1s and BCS class 3 compounds have high solubility and are differentiated by the permeability. And the BCS class 2 and 4s have low solubility, but these tend to have, and they're differentiated by the permeability. But for the BCS class 2 compounds, we're looking at different formulation approaches. Typically, for the drug substance, we're looking at, and the formulations, we're looking at salts, surfactants, particle size reduction, amorphous solid dispersions, and lipid formulations. But for the BCS class 4 compounds, it's the same options as the BCS class 2, but with the addition of the absorption bioenhancers. I'm just going to concentrate on the particle size reduction formulations. What we're sort of trying to do here is reduce this particle size to increase the solubility. So we start with the poorly soluble drug crystals, reduce the particle size via particle size reduction techniques such as nanomilling. We get the nanoparticulate drug crystals, and these are formulated into a drug product. And the overall aim of this is to increase the solubility and dissolution, which improves the bioavailability. For physiologically-based biopharmaceutics modelling, we do need a lot of characterisation data, and these are for both the drug substance and the drug product. And all these data can be put into the PBM model. In terms of absorption, we're mainly interested in different types of solubility measurements, the dissolution profiles, the permeability, the precipitation, and the particle size distribution. In terms of distribution, we're mainly looking at the log P, pKa, the blood to plasma ratio, and the fraction unbound in plasma. And there's also a couple other minor contributors as well. And we also need to take account of metabolism and excretion. On top of all this, we need some additional information, what species we're modelling, the dose and dosing route, the dose type, the prandial state we're looking at, and any demographics as well. So how's all this incorporated into the model? So we put all the data for the absorption, distribution, metabolism, and excretion into the model with the additional information and feed it into a tissue-based model, which is represented in the middle. And what we aim to get is a predicted PK profile for the drug product, and that's indicated by the top graph. And then on the bottom, we get information on various items. We can get an assessment of the in vivo from all the inputs. For the red line, the amount of the in vivo dissolution. The sort of blue line is the absorption of the drug product. The sort of purple line is how much gets to the portal vein, and the green line is the systemic plasma concentration. So what does this look like in terms of real-life situation for the modelling of nanoparticle formulation? These two graphs, they are very similar. All the solid lines, the profile lines are predictions, and the dots are the clinical data. On the left-hand side, we're looking at the effect of the nanofactor to predict the exposure of aprepitant, which is a nano-sized formulation in GastroPlus in the fasted state, using the default volumes and low absorption scale factors. And what you can see, there's a difference between the nanofactor on and the nanofactor off. And the nanofactor off gives the best prediction. On the right-hand side, we're looking at the impact of gastrointestinal tract volumes and different absorption scale factors. And the best predictions are with the reduced gastric volumes and the reduced absorption scale factors. And this is published data. So what are the challenges affecting the absorption behaviour of oral formulated nanoparticles? There's a number of them, and I'll just go over these one by one. In terms of solubility, it's the kinetic solubility that we're interested in. The kinetic solubility, we're looking at how it dissolves with time, and we can put any of those measurements into the model to use for the predictions. In terms of particle size distribution, the particle size distribution of the drug substance is quite easy to measure using particle size analysis. However, for the drug product, it can be different. We need to think of how it's normally formulated into a tablet, and the compression forces can cause aggregation or compression of the particle size distribution, and that's a lot harder to characterise. Also, wettability. We're working with low soluble compounds, and when these are wetted in the gastrointestinal tract, they can form aggregates, which again affects the particle size distribution. In terms of dissolution, these nanoparticles do tend to give fast dissolution, but this may not be representative of the in vivo dissolution. And then we need to take account of supersaturation and precipitation, which I'll come on to in a few minutes. But again, all this characterisation may not be representative of the in vivo situation. And lastly, it's permeability. It's looking at the drug substance, permeability, and this may change with nanoparticles. So in the sort of middle, we've got the spring parachute effect. With the nanoparticles, they do tend to form a supersaturated solution, and when they are sort of transferred into the intestinal, we want to maintain the supersaturated solution, but what we don't want is any precipitation, so we want the sort of top dotted line. However, because we're working with low solubility compounds, they do tend to precipitate fast, and the precipitation could be anywhere in between there. We don't know how they will perform in vivo until we actually get the clinical data and do a learn and confirm type approach. So what are the characterisation techniques that we've got? I'm excluding all sort of QC dissolution techniques, but The main ones are on the left in the early stages. There's the two-stage dissolution, where we look at how the drug dissolves, performs in dissolution in the gastric environment, and then the gastric environment is transferred directly into an intestinal media, and we can see the effect. Does it maintain supersaturation, or does it precipitate fast? This technique does tend to overestimate the precipitation. We can also look at dissolution and permeation in macroflux. This is a technique where you measure the dissolution and the permeation at a time, and in there you can see sort of a brown cell. There's a phospholipid membrane at the bottom of that, and you're looking at the rate of appearance of the drug substance API into the acceptor cell. Once we've got clinical data, we can revisit the model, and if necessary, we can use more advanced techniques like the BioJet system, which is a more advanced system of the two-stage dissolution, where you're going from a gastric compartment to the intestinal environment, but here the gastric compartment is going at a slower, is going at a specific flow rate, and you'll get more accurate assessment of the precipitation techniques in the BioJet. Another system is the TIM1 system, which mimics all the secretions and in the stomach and sort of the duodenum, using totally biorelevant media and enzymes in there, and from that you can also get an accurate assessment of the precipitation behaviour. So in summary, there's multiple challenges in predicting oral nanoparticle performance by physiological-based biopharmaceutics modelling, and the appropriate use of biorelevant and biopredictive methodologies will provide a better understanding of drug absorption and improve vertical-based modelling pharmacokinetic predictions for oral nanoparticles. Okay?